CD staff let's see. Oh, we don't want transcription. Sorry. Okay, I think we got it. Yeah, I got it. Okay, apologize. So welcome. My name is Bridget Monterossi. I'm a senior program coordinator with Washington County. And we have some other staff here that I'll go ahead and just allow them to introduce themselves. I'll just kind of go in order of folks that I see here at the top. Siobhan.
Hi, my name is Siobhan Burns. I am a communicable disease epidemiologist with Washington County. And I'll pass it to Jennifer.
Thanks.
Hi, I'm Jennifer Robertson, and I'm a communicable disease nurse with Washington County.
Great. Tyler?
Hey, good afternoon, everyone. Tyler Slattery. I'm a senior program coordinator with Washington County's communicable disease team, and I will pass it to Anne.
Hi, I'm Anne Schwint. I'm a communicable disease nurse in Washington County, and I'll pass it to Callie.
Hi, everyone. I'm Callie Gilliam. I'm the Infection Prevention and Access to Care Branch Supervisor with Washington County.
Awesome. And Kara, we can go ahead and you can introduce yourself too.
Hi, my name is Kara Magrill. I'm an older adult behavioral health specialist with Washington County.
Awesome. Thank you. Okay, so I'll go ahead and pass it over to Siobhan to give us an outbreak update.
All right, it should be loading here in just a second. There we go. So thank you all for joining us today. My name is Siobhan Burns. I am a communicable disease epidemiologist with Washington County Health and Human Services. Today, I'll be presenting an overview of what we anticipate for this year's respiratory season and how that compares to past seasons, as well as an update on how Washington County fared over the last year for outbreaks. Let's start with influenza trends. So this chart is from the Oregon Flu Bites report, and it shows the percent positivity of influenza tests by season as reported through the Oregon Influenza Lab Surveillance Program. This is a network of labs around the state that report back to the Oregon Health Authority. And this information provided through the flu surveillance program helps provide us with baseline data, allowing us to determine if there has actually been the onset of our flu season, as well as to estimate the burden of disease in the community. The gray dots and the blue boxes along the very bottom of the chart represent the two worst years of the pandemic, where there was very little flu transmission due to very intensified infection control measures being in place. Then in 2022, we had probably the earliest flu season we've had in a very long time that started in mid-October. During this time, masking requirements were discontinued in many settings, and we saw this rebound in flu cases that year. This year, we're getting back into the pre-pandemic trends and following a more typical onset of flu season starting in mid-November. This chart is showing the rate and distribution of influenza-associated hospitalizations by week and age group for the Portland metro area. Overall, we're starting to see an increase in flu cases with test positivity jumping from about 5% up to 10% positivity in the last week of November. Also in late November, we saw a sharp increase in hospitalizations for flu patients, especially in the 65 and older age group. Excuse me, just a second. Since October 1st, we've seen a total of 75 hospitalizations for flu in the Portland metro area, with 30 hospitalizations reported just in the first week of December alone. Although we're starting to see a return to the pre-pandemic trends, we must still be vigilant in promoting vaccination for high-risk populations. We really want to do our best to protect the most vulnerable by encouraging anyone eligible to get their annual flu shot, and that includes staff as well as residents. I also really want to thank any of the facilities that are providing on-site vaccination clinics, because ease of access is a major factor that contributes to staying up to date. For flu vaccination rates, we have tracked lower over the last 3 years compared to peak vaccination rates during the pandemic. You can see this here is the green, forest green line on the very bottom of the chart. We started out strong, but immunization rates have dropped lower than the last 3 years since the beginning of November. This next chart illustrates it a little more clearly. It breaks out those years individually, and you can see them as a side-by-side. So this helps us to visualize exactly how many shots were given during each year. And you can see during the pandemic, that was the highest vaccination rates we had seen with over 200,000 vaccinations. And that progressively dropped every year. We generally see a second push. Usually this happens right after Thanksgiving, between Thanksgiving and Christmas, that we get a little bump. After that, late October, early November time when most people go in for their shots. What is concerning, though, is that we are starting to see a general downtrend in the number of vaccines that people are going out to get for flu. With this downward trend, that means there's less shots overall, and that's concerning because the greater the community coverage we have, the better overall protection we have for high-risk populations. This line graph is also from the Oregon Immunization Program dashboard, and it shows statewide flu uptake over the last 5 years across all age groups. This graph contains data from flu week 19 of each season only, so it's a little bit easier to try and compare vaccination rates across each flu season. If we look a little bit deeper into this data, and we can see that there was a change in immunization rates over the last 5 years. In the 65 and older, it's actually been relatively steady across the state, and in Washington County in particular, it's even greater. I think we're sitting around 48% overall. But there has been a significant decrease in the ages 50 to 64, as well as the younger children 6 months to 6 years, with averaged about a 15% decrease in immunization uptake over the last 5 years between those two groups. This is also the age that many caregivers are providing support for either their aging parent or partner, or possibly providing childcare for a grandchild or young child in their home. And then those under 5 and over 65 are also the most likely to have serious complications from the flu. This is again why we really are pushing to try and get that message out for residents, staff, and caregivers to stay up to date on their shots. Next, we'll take a look at the respiratory syncytial virus, or RSV, information. And this chart shows the percent positivity for RSV antigen tests statewide over the last 4 years. This year's season is depicted in the orange line, and you can see there's been a sharp increase in case and test positivity between the end of November and the first week of December. With antigen test positivity jumping up to 17.5% this past week, as well as PCR tests at 2%, we are very likely to reach the official criteria for RSV season onset next week. The CDC criteria requires 2 weeks of over 10% RSV antigen test positivity, or greater than or equal to 3% of the PCR test positive for 2 weeks straight for the RSV season to be officially called as starting. RSV most severely impacts newborns and children under the age of 2, as well as those 65 and older, or those that are immunocompromised. This vaccine is available for older adults, and so we are recommending and encouraging anyone eligible to get their shot this year as well. This is a look back from last year to this year to see where all of our outbreaks kind of fell out. So this is running September through August from 2023 to 24, and then again looking at this year from 2024 going forward. So of course for the 2024-25 season, this is just year-to-date information. Last year we saw a total of 148 outbreaks. This was dominated by COVID, with 135 of those outbreaks being predominantly related to COVID, 3 flu, 2 RSV, 1 parainfluenza, and 7 norovirus outbreaks. Total reported illnesses was 1,773 people that reported sick or ill. This year, we have so far had 32 outbreaks, 30 of those being COVID and 2 of those being noro-like illness. Again, with COVID really dominating this, I think that shows just how quickly respiratory outbreaks spread and how difficult they are to stop once they've started. So implementing masking early, providing isolation for sick individuals, getting into that testing regime, and also starting any available prophylaxis for those that are sick or exposed as appropriate is really important. Also here, prevention is really the key. So again, staying up to date with the current COVID vaccine, your current flu shot, and RSV if you're eligible. Long-term care facilities represent a greater concern for serious outcomes, including death. So these outbreaks, if they're not detected early and effectively managed, they can have much more severe outcomes. We are also here to provide any information and advise you as far as infection control. We can also provide referrals for additional support, so please don't hesitate to reach out. Lastly, I just want to touch really quickly on gastrointestinal outbreaks. Thus far, we've only had 2 reported GI outbreaks for the 2024-25 season. But remember that most GI outbreaks are caused by norovirus, which is very low dose and it spreads easily. Cleaning up vomit or fecal material is a priority, but you actually have to clean the surface first and then provide disinfection. So you want to make sure that once the area has been cleaned, that the disinfectant is applied for the recommended amount of time. This may require re-wetting because some of them have a 5 to 10 minute disinfection period where they have to be applied wet as a wet surface in order for that disinfection to actually happen and inactivate the virus. Bleach solutions should be made fresh daily because chlorine is very reactive and will quickly degrade in solution. Refer to your MSDS or if you have a specific policy for your facility on what types of disinfectants you're allowed to use, as well as the appropriate PPE and what types of surfaces the disinfectant can be applied to. For GI illness, hand sanitizer is not effective and staff and residents should be using soap and water to wash their hands. Single-use hand towels are also recommended if there is a GI outbreak and they should be immediately laundered or to be using disposable paper towels. That's because we don't want any remaining vomitus or fecal material left on those shared towels that could be passed to the next person. And thank you very much for joining us today or listening in. If you're listening to the recording later, please reach out if you have any additional questions or comments, and I will pass this back over to Bridget.
Great, thank you so much, Siobhan. That's really helpful. Okay, I'd like to go ahead and introduce our next speaker, Kara McGrill, and just tell you a little bit more about her. She holds degrees in human services, nonprofit management, and has received specialized training in music therapy and dementia care. After completing a program in gerontology with Metropolitan State University in Denver, she began serving on faculty as an instructor in aging leadership and health professions. Kara has worked across the long-term care continuum in adult day, in-home care, memory care, and nursing home care. She started volunteering with the Alzheimer's Association of Colorado and eventually served on staff as an early stage program coordinator, during which time she launched a statewide creative engagement program with museums, arts, and other cultural partners. She has also contributed as a writer to Activity Connections Dementia Programming publication for activity and programming professionals. She is honored to be serving her community in her role as an older adult behavioral health specialist with Washington County Disability, Aging, and Veteran Services. Please welcome Kara.
Thank you so much, Bridget, and thanks everyone for being here today. So I was asked to come and discuss for the next 30 to 35 minutes or so boundaries, burnout, compassion fatigue, and moral distress, and hopefully give you a few tips on what to do about it. So in my current role as an older adult behavioral health specialist, we're oftentimes discussing very common mental health issues with older adults, mental health meaning depression, anxiety, using substances inappropriately in a way that's affecting quality of life, those kinds of things. And then we also like to work with teams that are caring for older adults because their mental health, your mental health is important as well. And we know that these roles and positions and environments that we work in can be very stressful. So that can lead to feelings of burnout and other negative health outcomes for the teams that we work with. So that's what we're going to be talking about today. We're going to define burnout, moral distress, compassion fatigue. Maybe some of those things are familiar and maybe you're not sure how they're different from each other. We're going to talk about that. We're going to look at some symptoms, how you can recognize if you're experiencing or if your teams are experiencing one of those things. And then we'll give you some really quick tips on what to do about it. So let's start with burnout. What is burnout? It's a condition characterized by physical, mental, and emotional exhaustion. We are just overwhelmed. Whatever is getting thrown at us, maybe it's been going on for a while. We just kind of feel like I am at my limit. I just can't handle anything else. And the way we get to a state of burnout, sometimes it's a result of us not being able to take care of our own physical and emotional health because we're so focused on our work, on providing care for someone else. So that's how sometimes we just neglect ourselves, or we just don't have the time, energy, or resources to take care of ourselves so that we can take care of others. So there's 3 components that result from burnout. And this is how we can start to determine, is this happening in ourselves or our teams? The first is depersonalization. So maybe I started my role, my work, and I really care about people. That's why a lot of people get into this world working in long-term care, because I care about others, older adults. I want to take care of others. But what happens when we reach burnout stage is we feel depersonalization. I no longer am able to see the people that I care for as people. I'm starting to see them more as tasks, things that I have to do to get through the day. Like, okay, what do I have to do today? Oh, I got 3 showers today. Oh my gosh, and it's in the memory care unit. That's going to be a really tough day. Rather than really seeing people as full, complex individuals, we start to depersonalize and we just see people more as tasks. Emotional exhaustion. So you might feel like you just have nothing left to give emotionally. Maybe somebody is in crisis at work, maybe experiencing emotional overwhelm, the person that you're caring for, and we just feel so exhausted emotionally. I can't connect with that. Somebody's crying in front of me and I just am feeling nothing. I just can't connect it with this. A good thing to watch for is when this is also happening outside of work. So maybe you get home and your spouse or partner or your kids, maybe they want to tell you about their day and you just feel like I have nothing left to give to that either. I just can't connect with it. I can't get present with it. I'm just not feeling that emotional connection. So that's how we can notice that in ourselves, emotional exhaustion. And then the third result of burnout is a feeling of a lack of personal accomplishment. You want to have meaning in the work that you do, and you want to feel like you are accomplishing something. But if you keep going in day after a day and you see that, gosh, I don't think things are changing, the people around me are not getting better, I don't know that what I'm doing is making a difference at all. If those feelings are present for you, you might be feeling like you're lacking personal accomplishment. So what does burnout do? Well, essentially it makes it so that we are no longer the people that we really want to be. Remember day 1 when you started this job and you thought, oh, the possibility. I'm so excited. I'm excited they picked me. And maybe I'm so disoriented, but I'm really want to be here and want to do good things and make waves in this role. But burnout changes that. So I can't even recognize that person anymore because I'm just going through the motions and just not getting anything out of it. So let's talk about stress versus burnout. Stress is the body's natural reaction when when we're experiencing a challenge or something that's demanding, and that is okay. Stress is actually what kicks us into gear when we are faced with something that's challenging. So stress is okay, but when we experience a lot of stress and we don't have an opportunity to either recover from the stress or an opportunity to kind of burn through that stress physically, then it kind of piles on. And especially if it's little stresses throughout the day over a long period of time, that's what can really lead to burnout. So, what causes burnout, especially in the work that we do in our long-term care environments? Well, here's the list of what causes burnout in general. See, as we go down the list, see how many of them you might identify as just being part of the job when you're working in long-term care. Lack of control, lack of resources, not knowing what to do, maybe a dysfunctional work or home life, extremes of activity, maybe high highs and low lows. So maybe there's a crisis one moment, and then maybe there's a period of boredom the next moment, and then a lack of social support. So some of these things you might say, ooh, this is a part of the work that I do. And some of it's just kind of part of the systems of long-term care. But I want you to look at this list and think, where do I fit in? Where does my team fit in? Is there something that could be changed on this list? If it's a lack of not knowing what to do, maybe we can have some influence on that. Maybe we can work on improving our skills or knowledge so that we can improve on that area, and that might reduce overall burnout. Or what about lack of control when teams are just told what they have to do and they don't have any input, especially when there's changes or challenges, they don't have any input and they're just told what to do, maybe with very little explanation. We all know why that can happen because we work at a fast pace. But what if we created a system or a way that people can give feedback, that they could help design their schedules or the workflow, or maybe we could just ask them for ideas on what they might do to improve a system. That might be a way to increase an experience of having more control over their work situation, and that might reduce burnout. What about lack of resources? We know that this can be really present in long-term care, where we feel like there is just not enough staff, not enough resources. It's just, we're always just overwhelmed with the amount of work that we have to do. So how can that be changed? How can we reallocate and make sure that people have the tools and resources that they need to do their work well? So these are just some things to think about to reduce feelings of burnout. So why do we see burnout in care, in caregiving services? Well, for a lot of the reasons that we've mentioned, but also there's a huge time pressure, right? We have this amount of time to get this many tasks done. Lack of control over work processes, maybe role conflict. Maybe something happens unexpectedly and you think, well, that's not my job. That should be the activity director's job to do that. And the activity director says, well, that's not my job. That should be the memory care director's job to do that. So there might be that role conflict. When we're dealing with humans, which are complex, their needs are going to come up. When they come up, are they going to be in front of the right person at the right moment? Probably not. So how do we resolve some of that role conflict so there's less of a feeling of it's not my job, it's someone else's? There could be relationship challenges between individuals or with leadership. Moral distress, we're going to get to that. Lack of support, we talked about, and then a lack of healthy boundaries and role definition. I'm going to give you a different word to use in place of boundaries. Sometimes we boundaries is a really buzzy word. How do we create better boundaries? And boundaries are good, but sometimes they're very rigid. So instead of boundaries, or in addition to boundaries, I'd like you to start thinking about limits, because that is something that we can pay attention to in ourselves in the moment. And it's not so rigid as I draw the line in the sand, this is a boundary. But how do I know when I've reached my limit? And when I get to that point, how do I ask for help? or maybe say no when somebody asks for a task and say, I don't have anything, I can't do this. I've reached my limit. I need more support. Do staff feel like they can ask for those things and communicate them without fear that there's going to be consequences? Personal factors can also contribute to burnout and care, just what's going on for the people, for persons at home. We can pay attention to this when there's particularly stressful times of the year, or moments in someone's life, or maybe something stressful going on in the news, especially for specific groups of people that might be impacted differently. Those are things that we can pay attention to and acknowledge, that those personal factors might, of course, impact people at work. All right, so this is the worst game that you'll ever play, which is Burnout Bingo. I'd like you to just take a look at this bingo card and see if you can get 4 in a row in any direction. These are 16 symptoms of burnout that we can experience that were defined by Laura Lipsky, and I have resource information at the end of these slides. So let's just go through a couple of them. Let's see, feeling helpless, hopeless. That's that sense again, lack of personal accomplishment. Doesn't feel like I'm doing anything. It doesn't feel like I'm moving the needle or helping anyone. And we may be doing that, but the important thing to listen to is, does it feel like that for our person, for the individual, for the team? Maybe a sense that that you can't ever do enough. So a sense that one can never do enough. I keep on, working on this thing and it's never enough. The work, the task is never done, never time to rest because I always have to be doing something. Hypervigilance. This might be an interesting one to look for in teams. Where do you have someone on your team that maybe feels, or maybe it's you, that feels like I am the only one that can do this. He only likes me, so I have to do it. He doesn't like anyone else. Or if I don't show up for that shift, then this thing is not going to get done. So that sense that I am the only one that's going to make this happen or make this right, that's actually could be a symptom that we are on track for burnout. We have to be able to allow and trust our teams to cover for us, because we have to not be there 24/7. And if you feel like that's not an option, that might be a symptom of burnout. Let's talk just a couple more and then we'll move on. How about let's look at inability to embrace complexity. So this can be where we are thinking about things in terms of a black and white scenario. It's either this or that. You're either going to do it right, my way, or you're not and you've totally screwed it up. When in fact, we experience our work and the world is usually as a continuum of, it's not either 100% or nothing, but usually situations are more like, that went pretty good, but there's things I might change, or that maybe didn't turn out the way I thought it was, but at least we learned this. That's kind of the ability to embrace complexity. And if you or anyone on your team is kind of locked into always thinking things in terms of it's either black or white, then that might be a sign of burnout, the inability to embrace complexity. Okay, so we've got a few more in that list, but we're going to move on to health risks of burnout. So why do we care about burnout besides staff turnover? What causes staff turnover is that we can experience actual health consequences of burnout. Excessive stress, the excessive adrenaline that we experience when we're in a hyper stress situation can actually have a negative impact on the body. Also fatigue, we can be overly fatigued and we could have problems sleeping. at night. So if you're feeling like I'm sleeping too much or too little, or I can't get to sleep or I can't stay asleep, that can be one of the risks of being in a state of burnout. We might have less emotional regulation, so experiencing sadness, anger, or just being irritable. We might try to cope with burnout by using substances. And this might have some cultural influences too, as maybe using alcohol or other substances to try and cope with some of these health issues or just the stress of feeling burnout. We are at higher risk for heart disease, have higher blood pressure, higher risk for diabetes, and we are more vulnerable and susceptible to illnesses. Did you know that teams that are experiencing higher rates of burnout actually call off of work, are more susceptible to things like colds, when they are experiencing burnout as opposed to teams that don't? So really interesting to pay attention to that, because if you've been getting a lot of call-offs, we're coming right after the epidemiology presentation about risks about that. There's also this component, our mental health can actually impact our physical health as well. So we want to pay attention to it for that reason too. Other reasons we care about burnout is our service quality. If we are not well and we're not taking care of ourselves, we're not going to be able to take care of other people very well either. So if you think of yourself as a resource in this puzzle of taking care of others, we want to take care of that resource. So think of it like a car. If your car is running close to empty and you think, gosh, I really need to fill up my tank, but I really just have to plow through and get to where I'm going. Well, you might run out of gas, and it's probably not going to be really great for the car to be driving on fumes for that last extra mile or however far you can get until it peters out. So we want to take care of ourselves. Pretend maybe, if it helps, that you're a machine as well, and we need to fill our tank, recharge our battery so that we can continue functioning and taking care of other people. Depersonalization is an issue because it can mean that we might lack those feelings of meaningful connection with at work, but also with our loved ones at home too. And burnout can impair our ability to provide safe, adequate, and supportive care. So we want to be at our best when we're doing a really high level skill, which is taking care of others that are quite vulnerable. We want to be doing that to the best of our ability. And that means that we can't be operating in a state of burnout to do that. All right, let's look at moral distress. What is moral distress? Well, kind of related to burnout, can be related. Moral distress is when our individuals that we work with or our teams maybe know the ethically right thing to do, but for whatever reason, they are unable to act upon it. And usually this is related to the systems that we work in. So I'll give you an example. Maybe I know that maybe a resident needs a ride to the doctor, and but the bus doesn't run on Tuesdays, let's say. Well, maybe I know that, gosh, I could just put her in my car and drive her right there, right now, and get her the care that she needs. But instead, we all have to wait a couple extra days until the bus is ready. That's maybe just an example of a system that you're bound by. So we might know the right thing to do. It's so easy, I can see it, but I'm unable to do it. And therefore, I see someone who is suffering or in pain or in distress, and I can't do anything because the system doesn't allow me to do what I know can be done. So this can be really frustrating, and this is how we can experience moral distress. And this happens a lot in healthcare settings, in mental health, in long-term care. And we want to be aware of the gaps in our system so we can come up with solutions, but also acknowledge just the individual feeling of sitting with moral distress. I see what this person needs or is asking for, and gosh, I might have an idea of how to do it, but I can't do it. So let's look, this is kind of a lot of words on this page. We're not going to go through them all, but basically, what is your resident helper relationship? Is this a collaborative relationship where you feel like you can be creative? When I say resident helper, I'm talking about our care team that's helping a resident. What does that relationship look like? On the left is a collaborative relationship, and this helps to reduce feelings of burnout. But on the right is a derailed or non-productive relationship, and this is what can increase our own feelings of moral distress and burnout, and also result in not as effective and safe care with our residents. All right, let's look at compassion fatigue. So this is our last definition. Compassion fatigue is a term that describes the physical, emotional, and psychological impact of helping others, often through experiences of stress or trauma. There's a couple different terms that are used a little bit interchangeably, and the language might be changing a bit on this compassion fatigue. So maybe you've heard of compassion fatigue. It's also known as secondary stress response or vicarious trauma. And sometimes now there's been some schools of thought that it's moving towards empathic fatigue. And not necessarily compassion fatigue. But we're going to focus less on the actual definitions of those words and just talk about what it is in general. So compassion fatigue happens when we are caring for people who are vulnerable, who are dealing with chronic or severe health issues, maybe when people are at end of life. So what are the triggers? Maybe when we are experiencing physical or verbal threats when we are providing service. So we're trying to help someone and they might be resisting in a kind of a big, intense way, resisting the care that we want to provide. For providing care to someone who experiences psychological distress, this can be depression, anxiety, maybe even thoughts of suicide or thoughts of death. So we're trying to provide care and somebody is feeling extreme unmotivation, extreme depression. That's where we can experience that compassion fatigue. If we are providing care in a dangerous environment, so I might have some risks to my person when I'm providing care? Is there a risk that I might risk for illness or disease? Or is it dangerous for me to be lifting heavy weights? Or are there sharp materials that I'm exposed to? So those kinds of dangerous environments can also result in compassion fatigue, where I'm really putting myself at risk to provide care to other people. We already mentioned end of life or terminal illness. And when we're providing care under a heavy workload, we have excessive demands or long hours that can all trigger compassion fatigue. So what are a couple things we do as we're wrapping up here? One is that we have to understand that recovery and wellness, well, there's some myths that are attached to those. So what are the myths? One is that it's indulgent or selfish. Nope, it's not. Remember, we have to, if we think of ourselves as machines, part of the big picture, we have to replenish ourselves, fill up our tank, recharge our battery. We have to do that if we're going to be effective at taking care of others. Another myth of recovery and wellness is that it is your responsibility to take care of you. Well, this is a cultural myth because in Western culture, particularly modern Western culture, we're very focused, especially in the United States, on independence as a value. which is actually an illusion because nobody is independent. We're actually interdependent. We have to take care of each other. That's the only way that our communities can function. So it's a myth that only you can take care of you, because it's not true. We have to allow for and invite each other to take care of everyone. Sometimes people think of wellness as a one-time event, like, oh, take a bubble bath and you'll feel good, or light a scented candle. Well, those things are nice. And if you enjoy those kinds of activities, that's great. But we're really talking about not adding something, not doing a one-time thing and everything will be solved, but really looking at the causes of that burnout and seeing how can we work in more wellness and recovery so that those causes are not activating a burnout scenario, or maybe they're not causing it at all. So we're maybe taking away some of those things that are causing that burnout in the first place. Some people think you either have it together or you don't. This is a myth. Sometimes people think that wellness is the absence of problems or challenge. That's a myth. And a lot of people think that maybe it's doing something. I should start yoga. I should do something. But actually, that's a myth as well. We need to think of it more in terms of the taking away. People tend to do healthy behaviors. It kind of goes together, but people tend to do healthy behaviors on their own if you are taking away their motivations for doing bad ones, or the situations that put us in a negative situation. So it's kind of a both and situation. Okay, so resiliency. This is the ability to transform challenge and adversity into wisdom, insight, and compassion. So remember, wellness is not the absence of challenge, because challenge and pain and things that are hard, that's just part of being a human person. We're going to experience those things. It's what we do when those things happen that's really more important. So this is a quote from the Chernus study. Stress does not necessarily cause burnout. People are able to flourish in stressful and demanding jobs if they feel their work is significant. So that's what we really want to focus on, is yes, it might always be a stressful environment, but are we feeling that work is significant? There's a couple different ways that we can learn how to do this. I'm going to show you this one model, the feelings quadrant, and then a couple other evidence-based methods of trying to reduce the experience of burnout in care teams. So the feelings quadrant, if you were going to place yourself on this quadrant, where would you place yourself today? Are you feeling more on the y-axis? Are you feeling more powerful or powerless? Where would you put yourself on that continuum? And then feeling more positive feelings or negative feelings. So where are you just even today in this moment on that x-axis? Are you feeling maybe a little bit more positive, negative, or maybe somewhere in between? And what we know about this feelings quadrant is that satisfaction in a work setting comes from feeling positive and powerful. And this makes sense to us now because we do know, of course, everyone who's been listening up until this point knows that burnout is caused by that sense of powerlessness. I don't feel good because I feel like I don't have control. So how do we feel more positive about our situation, and how do we feel more powerful? How do we move towards that satisfaction quadrant? Here are some ways to do it. One is, if we want to move, and it kind of goes around in circles. So let's start at the bottom with 1. If we want to move from negative feelings to positive, we can do things to work on letting go of the things that we don't have control over. So if it's something like a disease that we don't have control over, we can learn to, okay, we want to get better at letting go the things that I truly can't control, rather than try and be mad and wish things were different. we can learn to let go of some of the things that are just not serving us to hang on to and that we don't have control over anyways. Now, how do we move up from powerless to powerful? We could do a few things on teams. We can learn something and put our knowledge and skills to use to become more confident and competent in the work that we do. And we can work with our teams to form a plan on how to improve systems and situations that are causing a lot of stress and burnout, and then put that plan to work. And it is a circle. It looks kind of like quadrants and square, but it is a circle. So we start to feel more positive about the plan, but we're going to let go of the pieces of the plan that didn't work very well and use that as information to put it into a new plan. So it's a constant ongoing, how are we improving? And when I say improving, we're going to focus less on how can we get more showers done in less amount of time, or how can we do our tasks faster. No. We're focusing on how do we improve staff well-being while they're at work, and satisfaction. That's what we're focusing on improving. So this is the feelings quadrant. A couple other things we can discuss, or that we can take a look at today. And I know I'm going fast through these. I appreciate your time and attention. This is our resiliency toolkit. So we've got the R's here, and what we want to do is return instead of react, release instead of relax, reframe instead of repress or replay, and reconnect instead of report. So I'm going to give you examples on those, and then we'll end our time together today. So let's look at what we mean by return. So rather than reacting to a stressful situation and just going to the mode like, I got to fix this right away, we want to stop and take a breath, ground ourselves, tune into your 5 senses, observe what you're feeling, what you're thinking, and then proceed with intention. So the way that we could practice this is through mindfulness exercises, meditation, and this does need to be a practice. You'd want to do this every day at the beginning of a meeting before you just jump into, okay, shift change, let's go. Maybe you want to have a practice of, we're going to practice mindfulness so that we can proceed with intention rather than just being reactive. The second one is release. This is an interesting one that we don't always think about. We have our stress, and we have the thing that stresses us out, and we have to figure out a way to detach that stress that we experience in our body from the thing that is stressing us. And sometimes we don't always do that. So I can't get rid of necessarily, I can't just snap my fingers and get rid of the stress at work. There's going to still be 100 emails by the end of the day that people are going to be waiting on me. That's going to happen. That's the stress thing. But what I can do is recognize that that is causing stress, a physiological response in my body, and I need to release it. I need it to go somewhere. This comes from when we experience stress as early humans on this planet. It usually came in the form of maybe a big bear that was about to attack. And what did we have to do? Well, our bodies got charged up with a whole bunch of stress hormones so that we could run away as fast as we can. We don't do that anymore. I can't run away from the emails. But what I can do to release the stress from my body is mindful breathing, movement. Any kind of movement is actually, there's so much robust information about the importance of moving our bodies, but you can also do it through creative expression. Crying's okay. Laughter, physical affection, and then positive social connection. Third one is reframe. So there's a couple different ways that we can reframe a situation. I remember I said I learned to let go. That might sound a little weird, but when you think about it, there's so much in this world that we don't have control over. And if we carry that around in our bodies, it's actually not helpful. So how do we take the things that are challenging and turn it into a meaning-making experience to feel more, to go on that access from powerless to powerful, that I have a deeper, more meaningful understanding. And remember, when it comes to burnout, burnout is often caused by that lack of meaning and fulfillment, that depersonalization. So how do we create more meaning? How do we make time for that? Well, there's lots of different ways on this list. These are all different practices that you can use to maybe build in meaning-making experiences. I'm just going to focus on one, which is empathy. Remember that depersonalization with burnout. Well, how do we practice empathy? It can be a practice. Remember that myth of wellness. It's not, oh, you either have it or you don't. You're either empathetic or you don't. No, no, no. We can practice it. We can set an intention to practice it and the art of stepping into someone else's experience. I have a couple fun exercises on empathy that are a way to practice it. We don't have time today, but reach out, and if you reach out, I would be happy to give you more in-depth resources for any of the things that we're covering. So our last one here is reconnect. So a lot of our systems are based on reporting, and it's like, where does that go? So something happened, we're going to report, maybe we're going to tell somebody about it, but are we really feeling connected to our people and to our work? How do we get more connected? Well, one way that is evidence-based, and there's actually a healthcare model, a gratitude program that I'd be happy to share with you if you'd like to pilot that with your teams for a time, is gratitude practice. So gratitude is an affirmation of goodness. And the cool thing about it is that it is the goodness that comes outside of ourselves. It's a very hopeful, hope-building practice. So we have to acknowledge that there is goodness in the world, and when we practice finding what that is, it gets easier to feel more gratitude about the work that we do and for others around us. It's kind of this nice little catching practice where if you feel more grateful, you send it out more and they feel more grateful, and it leads to, again, that meaning-making experience. So that is it for me today. I hope I stayed on time well enough. I do have resources that are included at the end of these slides that I think Bridget's going to share with you all. And I think that's it. How do we do, Bridget?
Yeah, thank you. Just some excellent information. I learned a lot, and it was kind of timely for all of us probably. I know our CD nurses have been feeling pretty stressed these days too. So and I just want you to have a chance to do a pitch. You said that you can have folks like reach out to you, but you're a resource that the public can tap into at any time. And so I just want you to be able to have that opportunity.
Thanks, Bridget. Yes, my program is the Older Adult Behavioral Health Initiative, and there are 2 of us in Washington County, and we are a resource to you. We are available to you. We can come out and train your teams. We can do things like, work with you on the gratitude project if you want to do something like that. We can support your teams through crisis or suicide. Yeah, there's a lot that we can do. So if you're thinking about anything with behavioral health, mental health issues that you'd like to learn more about or get support on, we would be happy to help you. So you just need to reach out to us, Older Adult Behavioral Health Initiative. My name's Kara. My name's on the slides. And then we have Andy Wallace here in Washington County that can support as well.
Wonderful. Thank you so much. And I'll make sure to include your email address so folks can easily contact you.
Thank you, Bridget.
Yeah, thank you. And thank you all for attending. We appreciate your attention and time today. And as Kara said, I will be sending out the slides and then eventually sending out a copy of the recording. We have some staff that'll be out, but as soon as that gets uploaded to our resource page, I'll make sure to get that out. Thank you all.
Thank you, Bridget.